Madhushani, good evening, madam. You're muted.
Okay, right.
Yeah. Shall we start then?
Yes, of course, yes.
Right. People are joining. Now we have 27 in the audience. Good evening,
Okay.
everybody. I'm Dr. Asita. I'm the chair, Elderly Care Subcommittee in College of General Practitioners, Sri Lanka. So today we have Dr. Madhushani Dias. She's a consultant geriatric psychiatrist. Now it's called consultant in old age psychiatry. So it's a new field, and as GPs, we have to know many things in handling our patients, old patients. So let's start the session. I invite Dr. Madhushani Dias. Thank you very much, madam, for coming today. And also, I would like to thank the College of Psychiatrists for having you today. And they gave the permission, and we wrote to them from the College of General Practitioners. So thank you for taking our invitation and being here today. So we are here to listen to you, and the screen is yours, ma'am.
Okay, thank you very much, Dr. Asita, for that kind introduction and also for inviting me to do this talk. I try to share my screen.
We can see the slides, madam.
Okay, right. Okay, I'm not feeling a bit well today. I'm having a sore throat, so I might not be very clear at certain points. Please excuse me. Right. So today we are going to talk about psychiatry of the elderly. I hope you all can hear me well.
Yes, madam. Yes.
Okay, right. Thank you. All right. So we'll be looking at a few aspects of mental health in elderly people. Actually, when you take psychiatry of the elderly, it's a huge topic. So it's difficult to cover everything within a 1 hour period. However, I'll try to give you an overview of some common issues, and then we can have a discussion. So if you have any questions, queries, you can discuss those things and get a clear idea about the topic. Okay, so I'm glad that your college is holding this course or the series of lectures on geriatric care. So now we know that geriatric care is different to that of general adults. So it's same with psychiatry. Patients' mental health presentation can be quite different. So I'm sure you are aware of these statistics. So we know that the older adult population is on the rise, especially in developing countries. So we are going to have a large number of older people compared to young adult population in the near future. So this is going to be a big problem and a burden. So when you talk about mental health, it has been estimated that about 15% to 25% of these older adults suffer from at least one type of a mental health disorder. So it's 1 in 4 people, 1 in 4 elderly people are having a mental health problem. So it's becoming a huge problem. And the commonest mental health problems would be depression, anxiety, and dementia. So we'll be mainly focusing on these 3, and we'll be touching upon some other conditions and situations as well. Okay, so you might wonder why these patients or elderly people are at risk of developing mental health problems. Compared to adult population or younger population, these people are at a higher risk. So when we talk about etiology of any disorder, we now take this biopsychosocial approach, right? So it's very easy for us to formulate the etiology when we adhere to this model. So biological factors. We know with aging, there are many changes that happen within your brain. There will be neuronal shrinkage, changes to synaptic connections and changes in neurochemical pathways. And also these patients or people are prone to vascular brain disease, and they are affected by many other physical health disorders that can affect their brain function. And at the same time, they have they usually suffer from many physical health disorders, diabetes, hypertension, kidney diseases, and they're on many medications. So all this can lead to an increased risk of mental health problems. Psychological factors. What are the psychological factors? Again, with old age, people have to face a lots of psychological stressors. So starting from retirement, they lose their loved ones, so they suffer from grief, isolation, loneliness, and they have sense of worthlessness. They don't have any purpose for the future. So I'm just touching on a few of the factors because of the time constraints. And there are lots of social changes happening in these patients' lives, like again, retirement, loss of financial support, loss of loved ones, and many social changes are happening. So all these put these people at a very high risk of developing mental health problems. Okay, so why do we have to worry about mental health of these older people? Right. You might wonder why. So overall, compared to physical health disorders, mental health disorders can lead to increased risk of complications or adverse consequences in this elderly population. For example, these mental health disorders lead to poor quality of life in these patients. So, for example, if you take a patient with diabetes and a patient with depression, you can imagine that depression leads to a poorer quality of life compared to diabetes only, right? And these mental health disorders lead to reduced functioning. So these patients become dependent on others easily. So they become a burden. So family can't look after them. So it's becoming a huge problem. And also mental health problems lead to increased risk of cognitive impairment, especially depression, anxiety. These disorders can put these patients at a risk of cognitive impairment. So later on, they can go even into dementia. And mental health disorders or psychiatric disorders increase the risk of physical disorders. Again, for example, if you take depression, when you have depression, you are at a higher risk of developing a myocardial infarction or ischemic heart disease or a stroke or any other physical health problem, diabetes and many other physical health problems. And when they have a physical health disorder comorbid with depression or another psychiatric disorder, the outcome of that physical health problem is going to be worse. For example, if you take two people with stroke, one patient is having depression, the other one is not. So the outcome of the depressed person with the stroke is going to be worse than that of the person without depression. They don't engage with rehabilitation, their neurochemical processes are different, their coping strategies are different, so their outcome will be very poor. The other problem is suicide. We don't talk enough about elderly suicide. So if you take the overall rate of attempted suicide, the elderly usually do not differ. However, they are more likely to complete suicide. So when an elderly person talk about suicide, when they express suicidal thoughts, we have to take it very seriously because they really mean it. Compared to young people, they really mean it, and they are likely to use more lethal methods. So their rate of completed suicide is quite high. And their overall mortality, all-cause mortality, is increased when these patients suffer from a mental health disorder. So I'm sure now you understand the importance of identifying mental health problems and treating them promptly in this elderly population. Right. So we might face with a few challenges when you are to identify and manage mental health problems in elderly population. The most difficult scenario is that the symptoms of a mental health disorder can be easily confused with symptoms of physical illness or medication effects. For instance, again, if you take depression, so you know people with depression can present with loss of appetite, loss of weight, lack of energy. So all this can be a feature of a physical disorder as well. It can be a feature of CKD or diabetes. So it's difficult to differentiate. Anxiety can be confused with COPD or cardiac arrhythmias and so on. So there is lots of overlap and confusion. And the presentation also can be quite different. So we will be looking at how this presentation of mental health disorders in elderly people can be different to that of younger people. So they do not present with the typical symptoms of depression or anxiety or so on. And their assessment may be difficult. We know that they might be having cognitive impairment, sensory impairment, vision, hearing. So assessment may be difficult. And the most important thing is there are lots of myths and stigma concerning mental health problems in elderly people. So, for instance, people believe that memory impairment is quite normal for aging. And feeling sad, having lack of say lack of hope for the future, those things people might think that this is a normal consequence or normal feature of aging. So most of the mental health problems in elderly people go unnoticed and untreated. So I think as GPs, you are taking a good initiative here because you are the people who can identify these problems and manage them appropriately or refer them for specialized care. Right. So we will be looking at we will be looking at anxiety, depression, and dementia mainly. Can I please know whether you have a separate lecture on delirium or do you want me to cover delirium as well?
Madam,
Dr.
if you can, yes, mostly we
Right.
present into the GP setup, that's quite enough.
Okay, right. So we'll be looking at anxiety first because anxiety is quite common. It's actually the commonest mental health problems that is seen in elderly people. However, we don't usually take anxiety serious. We don't want to treat it. We don't want to take a history, right? So the patients may be presenting to you with lots of anxiety symptoms, but usually it's being under-recognized and under-treated. So these patients can have generalized anxiety disorder, panic disorder, phobias, obsessive compulsive disorders, and so on. And you might also have seen illness anxiety or health anxiety, that is increased anxiety about their own health. So all these are anxiety disorders. Okay, so these anxiety disorders need treatment and assessment because again, because of the reasons I have explained before, presence of anxiety can lead to increased mortality, increased motility, increased cognitive impairment, and poor quality of life. So recognition and treatment of anxiety is warranted. And also anxiety and depression are highly comorbid. So when you see a patient with significant anxiety, you need to look for depression as well. So in especially in elderly people, we recognize this condition called mixed anxiety depression. You can't say whether this is anxiety or depression because these patients have symptoms of both. So it's quite commonly comorbid with each other. And the patient might present with physical and psychological symptoms of anxiety. I'm sure you know what are the symptoms of anxiety, psychological symptoms, and then feeling restless, feeling anxious, and they have physical symptoms, restlessness, tremors, sweating, dryness of throat, muscle tension, headache, poor sleep. All these are features of anxiety. And in addition to these symptoms, these older people can have medically unexplained symptoms as well out of their anxiety. They might be coming to you with various physical or somatic symptoms. Right. So how are we going to manage anxiety in these patients? So I'm just going to give an overview because of the time constraints. So if you have any questions or queries, we can discuss them later. So the first task would be to exclude any physical disorder which is contributing to this anxiety. So we know conditions like thyrotoxicosis, angina, arrhythmias, hypoglycemia, all these conditions can present as anxiety. Okay? And sometimes the patient might be having one of these physical disorders plus severe anxiety. So in these instances, we need to treat the physical condition as well as the anxiety separately. And also, don't forget to look at the medication chart. So sometimes the patient might be taking a medication which can increase your anxiety. A common medication would be sympathomimetics given for asthma or other conditions. So it can lead to increased anxiety. So simple behavioral measures are usually adequate, like education, and if you have trained on relaxation methods, sleep hygiene, and simple lifestyle modifications like a balanced diet, increase physical activity, increase social connectedness, things like that, usually help with milder forms of anxiety. There are specialized psychological treatments as well. So if you think that the patient is suitable, you can refer the patient for a CBT or mindfulness-based therapies. You can also consider pharmacotherapy for significant anxiety. Usually the mainstay would be SSRI medications, or you can even consider SNRI medications. So when we discuss depression, we will be looking in more detail at these medications. So you might wonder whether we can give benzodiazepines to treat anxiety. So we know diazepam, alprazolam, clonazepam, these have been commonly given for patients for anxiety management. So there are lots of issues or problems with benzodiazepine use, especially in elderly people. We know benzodiazepines can lead to increased risk of falls, increased unsteadiness, fractures, and also long-term use of benzodiazepines can lead to cognitive impairment. And we know benzodiazepines lead to dependence syndrome. So after some time, the effect will be lost and the patient will need increasing doses of benzodiazepine. So the recommendation is that benzodiazepine should be avoided whenever possible in elderly people. However, in certain instances, you might want to give a short course of benzodiazepine, like a short-acting one, like alprazolam, for say 3-4 weeks time, until the patient's severe anxiety settles. However, if the patient is having severe anxiety or the patient is having lots of physical health comorbidities or significant depression is there, then you might want to refer this patient for specialized care. Okay, right. So we'll be quickly moving to depression. So before that, if you have any questions on anxiety, maybe we can clarify it and go on to the next one. Do you have anything to ask?
There's one question in the chat box, madam.
Yes. So yeah, so we can discuss it when we are discussing depression, right?
Yes.
Right. So we quickly move to depression. Right. Okay. So depression is also very common in elderly people. So this is just a common, just a overall prevalence rate. Yes, you can see that when you consider the rates of depression among general young people and elderly people, there's not much of a difference. However, again, the problem is when elderly people are having depression, the complications are more severe. So that's why we need to identify and treat elderly depression vigorously. So just to show you how important and how severe the problem is, so this is one of the studies done in the community in Sri Lanka. So 13.9% of elderly people had depression. So that's a quite high rate. We know that in medical conditions like stroke, Parkinson's disease, dementia, heart disease, diabetes, COPD, now these conditions, people having depression the risk is very high, especially after stroke. The risk of developing depression is quite high. So it's important to look for it and treat it. How do we recognize late life depression? Okay. So the problem here is usually when elderly people are having depression, they might not present with the typical symptoms of depression. So we know when we study depression, we learn that they present with persistent low mood, lack of interest, lack of enjoyment, right? So these are the symptoms we usually look for. But elderly people usually will not present with a low mood. They will not come and tell you, doctor, I'm not feeling very happy, I'm feeling low, I'm feeling depressed. No, they will not tell you that, right? They will usually present with features of anxiety or agitation, right? Or they can present with recurrent somatic symptoms. I'm sure you encounter lots of patients who present recurrently with unexplained medical symptoms to your practices. So they might be having actually depression. In our country, the common somatic symptoms are multiple pain symptoms and burning sensation of the body. Quite interestingly, they have these symptoms in our Asian countries. Another presentation could be memory impairment. So they might not tell you anything about how they are feeling. They might present you with memory impairment only. And also sleep problems. So when patients present with these symptoms in their old age, you need to look out for depression in these patients. Another problem is there's something called mask depression or smiling depression. These patients might be feeling quite depressed inside, but to outside, they don't show it. They might be actually smiling, or they might feel quite happy and reactive. But when you dig deep into their mood, you will find that they are quite depressed. And as we discussed before, these symptoms, the other symptoms of depression might be confused with symptoms of a physical health disorder. Okay. Right. So I believe that you will be able to look out for depression and identify depression. So what we need to do is, when these patients are presenting with suspicious symptoms, we need to spend some time with them and ask specific questions. So they usually do not come up with depressive symptoms very easily. So you'll have to take time, reassure them, build up a very good relationship, then they will come out with depressive symptoms. Okay, right. So how are we going to manage this depression now? So I must say that managing elderly depression is quite challenging. Okay. One reason for that is usually this depression is comorbid with physical health problems. So, and giving them certain medications can't be given for elderly people. And by its character, this elderly depression is usually quite resistant to antidepressant medication, in the sense that they take a longer time to respond. So usually we say that a person will respond to antidepressant medication after 2 to 3 weeks of treatment. But for elderly, you might want to wait for a bit longer. So it might take up to 4 to 6 weeks in these elderly patients. So what are we going to do? Now a patient is coming to you with the features of depression, right? So your first task would be to assess for any physical causes which is leading to depression. We know hypothyroidism leads to depression. Vascular brain disease. So after a stroke, you might get depression, or due to small vessel disease of the brain, which might not be evident in the physical examination, might be the cause for this patient's depression. And vitamin deficiency, especially vitamin B12 deficiency, vitamin D deficiency, folic acid deficiency can present as depression. So there are many other causes I'm not going to discuss everything. So you need to do a thorough physical examination and do necessary investigations to rule out any treatable cause for this patient's depression. And also it's important to check the medication list. Again, we know certain medications lead to depression, especially beta blockers, and many other medications can lead to depression. And then optimizing medical conditions is also very important. As we discussed before, these depression and physical health conditions are highly comorbid. So when diabetes is not controlled well, depression can get worse. Likewise, when the depression is untreated, diabetes can get worse. So we need to treat the medical condition and depression at the same time. And we can optimize hearing and vision, mobility, because all these contribute to depression. You can also advise on lifestyle modifications. Again, diet, exercise, social activity. All these are very important. Now we talk about what is called social prescribing. We prescribe the patient to go to a gym. We prescribe the patient to go and meet a friend or join a club. So lifestyle modifications are important. For mild forms of depression, psychological therapies might be enough. So there are different psychological therapies. We will be just looking at them later. And I'm sure you are looking forward to learn the pharmacological management, which is the most commonly used management, right? So antidepressants can be used to treat moderate to severe depression. Usually for mild forms, antidepressants are not needed. So what are the antidepressants that can be used in elderly people? So we have commonly seen that fluoxetine being prescribed in elderly patients. So fluoxetine is not recommended to be used in all the patients. The reason is that fluoxetine has a very long half-life. So it has a 7 days half-life, and it has an active metabolite which will stay in your body for another week. So it's very long acting, and the side effects are also more with fluoxetine. So in elderly, fluoxetine is not recommended. SSRIs are the first line treatment. So the safe options are sertraline, which is usually freely available even in the government sector. It's usually available. And the other medication, which is usually can be safely prescribed, is citalopram and escitalopram. Right? Again, just be mindful, citalopram and escitalopram can lead to QT interval prolongation. So if the patient is having any heart disease or if the patient is on other medication which can lead to bradycardia and arrhythmias, just be mindful. You might have to monitor ECGs of these patients if you are going to prescribe citalopram and escitalopram. Sertraline is usually safe. Mirtazapine is also another good option. If SSRIs can't be given or if SSRIs are not effective, we can go for mirtazapine. So mirtazapine leads to sedation, which is a good thing in depression, because with depression, they develop sleep impairment as well. So it leads to sedation, and also it can lead to increased appetite and weight gain. Again, this can be beneficial in depression where you have loss of appetite. Mirtazapine can also be combined with SSRI or SNRI medication safely. Mirtazapine is usually a good option. SNRIs also can be used in elderly people. So we have venlafaxine and duloxetine. I'm sure you might be using duloxetine as an analgesic medication as well, especially for neuropathic pain. So if the patient is having comorbid neuropathic pain or any pain syndrome, duloxetine will be a good option. So with, with SNRI, we need to monitor blood pressure closely. Tricyclic antidepressant medications like amitriptyline, imipramine, and clomipramine, these medications are not recommended to be used in elderly people because of their serious side effects. So these medications can lead to serious cardiac side effects, CNS side effects, and also anticholinergic effects, and so on. So somebody wanted to discuss about glaucoma as well. So since tricyclics have significant anticholinergic effects, no, it's not recommended. It can worsen glaucoma. SSRI also can rarely worsen glaucoma. However, it can be safely used because it's not very common. Mirtazapine is usually a safe option in glaucoma. Right? So with all these medications, the golden rule is that you have to start with a very low dose and increase very slowly. Okay? So for instance, we know now sertraline we can start with 50 milligrams, but if the patient is very old and frail, you might want to start with 25 milligrams. And dose increment has to be very slow with any medication. Citalopram or say escitalopram again, usually in younger people, we can go up to 20 milligrams, but in elderly people, the recommended daily dose is 10 milligrams. So there are differences in recommended doses as well. However, if the patient is tolerating the medication well, you can increase the dose and see if the patient is all right. Excuse me. Right. So there are a few messages I just wanted to give you regarding these medications. So one thing is, with SSRI and SNRI medication, patients can develop hyponatremia due to SAIDH. So elderly patients are more prone to develop hyponatremia, especially if the patient is having multiple medical problems, female patients, frail patients, poor dietary intake, on losartan or any other sodium lowering medication, the patient can develop serious hyponatremia. So it's recommended to check serum electrolytes before starting SSRI or SNRI, and after a few weeks, say after 2 to 4 weeks, after starting SSRI or SNRI, we need to check for hyponatremia. And also the other important fact is, if the patient is taking aspirin, clopidogrel, warfarin, or any other medication which can increase the risk of bleeding, that risk can be further increased when you prescribe SSRI or SNRI together with that. So in such cases, we might want to look for an alternative, like we can start mirtazapine instead of SSRI, or the risk can be minimized by prescribing a PPI medication, like say you can just give some omeprazole together with sertraline if the patient is also on aspirin. I believe that you are clear about the pharmacological management up to now about antidepressants. Right. Sometimes low-dose antipsychotic medications can be used to augment the antidepressant medication, or if the patient is having comorbid psychotic symptoms. We know with depression, sometimes patients can develop psychotic symptoms. In such instance, we can give low-dose antipsychotics. But my recommendation is that if you see a patient who you think that need antipsychotic in addition to antidepressants, it's better to refer that patient for specialized care. ECT is also another option you might consider for severe depression or treatment unresponsive depression. Again, you might want to refer. There are different psychological therapies. Again, I don't think you have facilities to facilitate these therapies in your practices or in primary care. So if the patient is looking for any psychological therapy, or if the patient needs them, better to refer these patients for further care. Right. Do you have any questions regarding depression? Since we are going to move to dementia now.
Yes, madam. With sertraline, how much pain it can control, like post-op depressive patients?
Okay.
Will it reduce pain also?
Sertraline is not known to reduce pain actually. Usually it's duloxetine and SNRI which can improve pain symptoms. But the subjective experience of pain can be changed, because when you feel depressed, you tend to feel pain more, right? So when the depression improves, the patient might cope better with pain. Okay?
Thank you.
Okay.
Excuse me, madam. What is the ideal dose for the sertraline dose for the elderly people? Usually
it's like this now. You can start with 25 or 50 milligrams and gradually go up on the dose. So it depends on the patient characteristics. Some patients improve with 100, some patients will need higher dose. Usually the recommended upper limit is 200 milligrams.
Is it divided dose or octet dose, madam? Should we?
SSRIs are usually given as a morning dose because it can lead to insomnia. But some patients can develop increased sedation. So in that case, you will need to give as a nocte dose. Some patients can't tolerate a high dose, single dose. In that instance, you can give as a divided dose. There's no hard and fast rule.
Thank you, madam.
Yes, another question, one question, madam.
Yeah.
When we are prescribing this amitriptyline,
Yes.
usually we are prescribing amitriptyline in elderly patient for this neuropathic pains.
Okay.
Then my question is, it has so many side effects, no? But my experience is that the amitriptyline is a very good choice for the all aches and pains in elderly, especially.
It's
then,
like this. Maybe you
is,
maybe what's the dose usually are using?
You either 10 milligram or 12.5.
Yes, that's right. So for depression, that dose is not enough. For depression, you need to give higher doses, at least 100 milligrams. So at least 50 or 100. So at those doses, the side effects are usually intolerable. So small doses are fine, I guess.
It means that dose is not effective in managing the depression.
No, it's not. It's not enough. So you can combine a low dose of amitriptyline can be combined with SSRI, but you need to look for side effects like serotonin syndrome and other stuff. But it's not there in guidelines, but in practice you can use it. Okay, shall we move on now? Okay, thank you. So we are moving on to the biggest topic, dementia. Right. So dementia, it's very important to identify, understand the definition of dementia, because we tend to believe that all the cognitive impairments are dementia. So I've seen many patients who have been started on anti-dementia medications by various specialists. However, these patients, or not all these patients, have actual dementia. So dementia, the definition is that the patient has a decline of their cognitive functioning from the previous level. So always the previous level is important, because the previous level it will be different from a clerk to a teacher, to an executive officer, to a laborer. So we always need to compare the cognitive decline with the previous functioning of that particular person. And you need to establish at least impairment in 2 or more cognitive domains. So we talk about these cognitive domains: memory, executive function, attention, language, social cognition, psychomotor speed, visuospatial functioning, and of these cognitive domains. So I don't have time to go through each of them. And this impairment should significantly interfere with that person's ability to function independently. So that is the key here, because sometimes even with normal aging, people might experience subtle cognitive impairments. And also we talk about this mild cognitive impairment, where cognitive impairment is there, but the patient can function independently. So these 2 conditions are not dementias. So there should be significant cognitive decline affecting the day-to-day functioning of that person. So when you ask about the day-to-day functioning, you need to ask about their basic activities of daily living, like say cleaning, grooming, eating, drinking, and all that. And also instrumental activities, more complicated activities such as shopping, cooking, managing medication, traveling, and all those things. Okay. So how do we diagnose dementia? Now since we know the definition. Yes.
What is visuospatial and visuoperceptual?
Sorry.
What is visuospatial and visuoperceptual mean?
Yeah, both are. I mean, they are used interchangingly. So visuoperceptual is your ability to kind of identify the 3D, understand the 3D space, and your ability to understand your position in relation to that. So for instance, you need good visual perceptual skills to navigate through the roads, drive, or walk, say, if you are in a cluttered environment to get to some place. So it's your awareness about the 3D space, something like that. Okay, so when you have impairment in visual perceptual abilities, you might not be able to come back home after going out, or you might not be able to find your room. You might not be able to reach out for something and grab, or say operate machines, press on the correct button, things like that. So, so it's a broad thing. Right. So since we know the definition, diagnosis, now we know how to do the diagnosis. But first, when a patient is presenting to you with cognitive impairment, before considering dementia, there are some few things you need to consider as differential diagnosis. One is delirium. So we'll be touching on delirium later. So delirium presents with acute onset cognitive impairment, whereas dementia is usually a progressive, slowly progressive problem, right? And the other thing is depression. We discussed earlier that commonly elderly depression can present with cognitive impairment. So you need to try to differentiate whether this is depression or just dementia. So it could be an organic brain disease, it could be an encephalitis, autoimmune encephalitis, or a brain tumor. It could also be other mental illness. For instance, a patient in a manic episode or a psychotic episode can have cognitive impairment at the same time as a result of their psychiatric disorder. So you have to consider all these. Then we go for cognitive, we need to establish cognitive impairment. For that, you need to assess cognitive function. So you can ask the patient and the family to look for subjective evidence, but we need to establish the cognitive impairment objectively as well. So I think at primary care level, you can use certain screening tools. Mind you, all these are screening tools. These are not confirmatory of dementia. So we have MMSE. The problem with MMSE is it's not very sensitive to detect mild forms of dementia or mild forms of cognitive impairment. Then we have MOCA. So all these are available in Sinhalese and Tamil also. So Montreal Cognitive Assessment is also, it's a very good tool, but it takes a bit longer than the MMSE. And then we have this, I'm not sure whether you have heard of this or not. We have a tool called MiniCog, which is a very brief tool. It has only 2 tests, very easy to use in primary care setting, and it's very, very sensitive. So you can, later on, you can just do a research on these tools and use one of these as a screening tool. The problem is some patients now say, as I said, MMSE is not very specific. So for a person who had poor premorbid functioning, MMSE could be a good tool. But say if you want to assess cognitive functions in a doctor, MMSE might not be a good tool because he will anyway do the MMSE really well despite having cognitive impairment. So depending on the patient characteristics, you can choose between these screening tools. However, if the screening is positive, that does not mean the patient is having dementia. Dementia is a clinical diagnosis. So you need to combine all our assessment findings in order to achieve the final diagnosis. Right, so now we have established cognitive impairment. We have screened for. Then we need to look at functional impairment as well. Is this patient independent in his daily functioning? For that, again, you can ask from the patient and the relatives. And also there are objective tools as well. Right. Then we need to rule out treatable causes. So dementia, there are different, I mean, there can be hundreds of causes for dementia. So we know neurodegenerative causes are the commonest, like Alzheimer's, Lewy body dementia, and vascular dementia. However, certain dementias can be potentially treatable. For instance, normal pressure hydrocephalus, hypothyroidism, vitamin deficiencies, those are potentially treatable conditions. So we need to assess the patient for these treatable causes with our physical examination and blood investigations. Then we can assess for etiology also, whether this is Alzheimer's or whether this is vascular. Usually we can do it with neuroimaging. Right. So at the primary care level, so your task would be to identify these cognitive impairment and maybe do the screening and rule out treatable causes. And then you can refer the patient for specialized care, because then the patient will need a proper cognitive assessment and a full assessment of other aspects as well to make the final diagnosis and discuss the medication options. Right. So in addition to the cognitive problems, we know these patients present with different types of behavioral and psychological disturbances, which are referred to as BPSD. So they are quite common. More than 90% would have these problems. So the common ones would be agitation, restlessness, apathy. Apathy means they don't, when they don't have any drive or any motivation to do anything, they are just blunt, no reaction, they're not reactive. They can have disinhibition, aggression, wandering. They can have psychotic symptoms, so they can have delusions. A common delusion would be the belief that other people are trying to steal their belongings. And visual hallucinations can be there. Depression, mania, anxiety, quite common. Sleep problems, right? So there are lots of different types of behavioral and psychological symptoms. Okay, now how are we going to manage dementia? So cognitive enhancers, we will discuss. So we have to consider cognitive enhancer medications and manage behavioral and psychological symptoms. There are non-pharmacological therapies which are beneficial for cognitive symptoms as well as behavioral symptoms. So the most highly evidence-based treatment is called cognitive stimulation therapy. So we have now translated the cognitive stimulation therapy manual to Sinhalese, and we have started a pilot project as well, and we have conducted training as well. So locally also, you might, if you are interested, you can start cognitive stimulation therapy in your setup. There are other types of therapies which need referral to specialized centers. At primary care, what you can do is advising on lifestyle modifications. So these are also as efficacious as medications, or more important than medications in managing dementia. Again, a healthy diet, physical exercise, maintaining social contacts. These three are very important in reducing cognitive and behavioral symptoms. And also we need to look at their physical health and their social and emotional needs. Right? So when I say social needs, so they have financial issues, caregiver needs, and lots of problems. So dementia, actually, it's very difficult to cover within a very short time. Right. So we look at the cognitive enhancers. So cognitive enhancers are recommended in Alzheimer's dementia, Lewy body dementia, and dementia due to Parkinson's disease only. Okay. So cognitive enhancers do not alter the cause of the illness. They don't do anything on the underlying neurological process or neurodegenerative process. They only give some symptomatic kind of relief. So these medications can have some benefits on the cognition, behavior, quality of life, patient's functioning, and that's all. So the disease progression will anyway happen. So we have two types of medication, cholinesterase inhibitors. We have donepezil, rivastigmine, and galantamine. And the other group is memantine, which is an NMDA receptor antagonist. So these medications need to be started at a low dose. So you need to know the regime. Donepezil, we start with 5 milligram, and only after 4 weeks that we can increase the dose. Rivastigmine can be increased on a weekly basis. 2-weekly basis, memantine can be increased weekly. Okay? An important point is donepezil and rivastigmine, they can lead to bradycardia and heart blocks, especially in predisposed patients. So if you have any patients who are on donepezil or rivastigmine under your care, so it's your duty to monitor their pulse rate. Ideally, you need to do an ECG before starting the treatment and then monitor their pulse rate for any bradycardia. Right. So this is just the guideline recommendation. It's a bit too much to read. Okay. So acetylcholine esterase medications are usually recommended for mild to moderate Alzheimer's disease. Okay. Memantine is recommended for severe Alzheimer's disease. If a patient can't tolerate acetylcholine esterase inhibitors or donepezil, or if the patient can't be given that medication due to some other contraindication, then you can give memantine for moderate disease even. Okay. So that is how you start treatment. If the patient is already taking donepezil, right, and now the patient is going to the moderate or severe disease, then you can consider adding memantine on top of that. Right, so that is a summary of all this information that is there. Right, then you might wonder whether you need to stop medication, because earlier we used to say that we need to monitor the cognitive functions, and if there is no benefit, we stop the treatment. But now the recommendation is that it's better to continue the treatment, even donepezil. We need to continue, because if we try to stop the medication, the patient might deteriorate, especially their behavioral symptoms can get worse. So the nice recommendation is that the decision to commence a patient on one of these medications need to be done at the secondary care specialized in managing dementia. So it could be a psychiatrist, a geriatrician, or a neurologist. So when you have patients, you can do the initial workup, refer the patient for specialist opinion to make the diagnosis and prescribe medication. Then you can take over again and initiate the prescription, monitor, and so on. If the patient has been already started on donepezil, you can consider adding memantine later on if needed. Right. So, are there any questions regarding cognitive enhanced medication?
Madam, donepezil, what's the maximum dose you can give?
Yes, it's usually the recommended dose is 10 milligrams daily. Okay. But in certain countries like USA, people use higher doses, but they have the extended release preparation. So they sometimes use 23 milligrams a day, but we don't have that preparation. So for us, it's 10 milligrams. Okay. For memantine, it's 20.
Yeah, I have seen usually psychiatrists, they have they first start with donepezil, then remove it and add the memantine, but not together.
Yes, that can be done, but the current recommendation is that you don't stop donepezil, but you start memantine on top of that. But also you have to consider the cost as well, right?
Yes.
So in private sector, it's, you can't afford to buy both donepezil and memantine. They're quite expensive. So there are other factors as well that you need to consider, right?
Thank you.
Okay, right. So now we are coming to the most difficult part, managing BPSD in these patients. Right. So when the patient is presenting with behavioral or psychological problem, we tend to give medication. But medication should be the last resort in managing BPSD. Before considering medication, we need to consider non-drug measures, right? So the reason is that usually these patients develop these behavioral and psychological problems in response to some underlying problem. So it can be a physical problem, like it can be pain symptoms, it can be hunger, incontinence, constipation, right? or it could be just emotional needs, feeling lonely, boredom, anger, frustration because they can't do things on their own, right? So whenever possible, I know it's quite difficult with the time constraints we are facing with. However, whenever possible, we need to look for the triggering factor. Okay? So the research has shown that pain is a very common reason for behavioral and psychological issues. So before considering some psychotropic medication, we can give a course of paracetamol or some other analgesic to see whether the patient's behavior improves with that. So, so that's a key message. So consider analgesics if the patient is presenting with new behavioral symptoms, right? And also we need to look for, we need to consider physical examination, and if needed, when needed, we have to consider investigations as well. Another common reason for behavioral problems is urine infections. So we can easily do a UTI, or sometimes you can give a trial of antibiotics to see whether the patient improves. So, right. And there are other behavioral management strategies which usually are done by occupational therapists. So if the patients are presenting with severe problematic behaviors, you can refer for a secondary care center for occupational therapy input. Right. So pharmacological management of BPSD, the problem is there's no clear evidence. These are not very effective, and these medications have serious side effects, right? So for instance, we know that antipsychotics can increase mortality in patients with dementia. Antipsychotics can increase the risk of stroke, increase the risk of pneumonia, increase the risk of cardiac events, right? And also antipsychotics can lead to sedation, falls. Severe extrapyramidal side effects can occur. We know when you give antipsychotics, patient develop PPSC, but when you stop the medication, they improve. But what happens in elderly, sometimes these EPSC can be permanent. So before considering psychotropic medication, we need to carefully analyze the risk and benefit. Start with the lowest dose possible and increase very slowly and use for the shortest time. When the patient has improved, you can gradually tail off the medication. No need to continue this medication lifelong. Right. So what are the pharmacological management options? Do we have to stop right at 10 o'clock, or can we have 5 more minutes?
10, madam.
Okay, right, thanks. Right, so pharmacological management. So as I mentioned before, we need to consider analgesics first. Excuse me. And also, when we start the patient on cognitive enhancers, those medications can also have some effect on behavioral issues. So if we are going to anyway start this patient on donepezil or memantine, we can wait and see if the patient improves. Antidepressants can be used to treat agitation, depression, and apathy, although they don't have robust evidence. You can use sertraline or mirtazapine to help with agitation, depression. For apathy, you can use sertraline. Antipsychotics can be used in certain instances. I will discuss it later. But the problem, again, as I mentioned before, is significant side effects and risk of increased mortality with antipsychotics. Sometimes you might want to use some benzodiazepines. Again, the problem is benzodiazepines can hasten the cognitive decline, can lead to pneumonia, increased sedation, falls, hip fractures, and lots of complications can happen with benzodiazepines. So if you really want to give some benzodiazepines, just give a short course, maybe as PRN, SOS, rather than a regular medication, and stop as soon as possible. Promethazine also can be used to help with sleep and sometimes maybe for agitation. But again, when you use promethazine long term, it can worsen the cognitive impairment. Melatonin also can be used to treat sleep problems in dementia. it has limited evidence, but the good thing is melatonin is a good drug. I mean, it's usually safe drug, not much of side effects. So you can give a trial of 3 milligrams and then increase to 6 if needed, and just see whether the patient's sleep improve with melatonin. Right. So coming back to antipsychotic used in dementia for the treatment of BPSD. So antipsychotics, please consider it as a last resort. If you can settle the patient with some antidepressant or cognitive enhancer medication, or maybe with promethazine, try that first. Antipsychotics can be used to treat agitation and aggression and also psychotic symptoms. If these symptoms are very severe, then you can't wait until you do this behavioral management and all that. And also, if the patient is putting himself or others at risk due to these behavioral symptoms, again, we can't wait. Then in these two instances, we might want to start the patient on some antipsychotic medication straight away. So again, carefully consider risk and benefit. And start with a very small dose. Usually it's half the adult dose, right? So you can see the examples in this green box. So if you take olanzapine, we know in adult people we can start with 5 milligrams, but for a patient with dementia or for elderly patient, it's usually 2.5. Risperidone, start with very small doses like 0.25 milligrams. I have seen dementia patients being given 2 milligram BD, 1 milligram BD, very high doses, so they can't tolerate it. So we start with 0.25 or 0.5 milligram daily and increase very slowly. Okay? You need to assess the patient at least every 6 weeks to look for any side effects and also to see whether this patient needs this medication further. If the patient has improved, again, we can consider tailing it off after some time. Also, if the patient has not responded to the medication, no point in continuing. Again, we have to consider tailing off. And antipsychotic, if we are going to give antipsychotics, we need to monitor the patient, blood pressure, pulse, weight, fasting blood sugar, urea electrolytes, liver functions, renal functions, lipid, ECG. So it's very important to monitor before starting antipsychotic medication, and also after starting the medication also we need to regularly monitor these parameters in patients who are on antipsychotic medication. Okay. So just a few words about delirium. So delirium is also called acute confusional state. So in delirium, you see cognitive impairment, a global cognitive impairment, but this is acute in onset. Right? So one key factor is, feature is acute in onset, and usually it's fluctuating. So in the morning, patient might be really lucid and conscious. In the afternoon and in the night, patient might be really confused. And there is some impairment of consciousness. If you take a patient with dementia, usually patients are conscious and alert. You can have some meaningful connection with the patient. But in delirium, the patient's consciousness is muddled or confused. So those are the 3 key features of delirium, which you can use to differentiate from dementia and other conditions. And delirium is a neuropsychiatric condition which is always due to some underlying physiological process. Right? So treatment of delirium is by finding and treating that underlying condition. Okay? The problem is delirium comes with a very high rate of mortality, and later on they can develop dementia. So it has to be taken as a medical emergency. So ideally, a patient with delirium can't be recommended to be treated at home. I think the patient needs to be admitted to a hospital and assessed and treated for. The causes can be, they're huge. So it could be infection, could be electrolyte disturbance, could be hypoglycemia, could be heart problems, kidney problems, could be any derangement of the body. It could be constipation, it could be poor vision. So there are lots of causes that you need to consider. So managing delirium is always looking for and treating the underlying cause. That is the only treatment which can cure delirium or improve delirium. The patient needs lots of supportive management during the recovery process. So that's why the patient needs to be in a hospital. So hydration, nutrition, mobilizing the patient, temperature management. So there are lots of things which need to be done. Psychotropic medications can be used if the patient is very agitated. You can't use other measures. So patient is really aggressive, high risk, then we can use very small doses of antipsychotic medication, very small doses. Once the delirium is settled, we need to stop the medication straight away. Right. So I think we'll just stop there. I have just one more slide on grief. Right, and psychosis. So I can send you the slides so that you can just go through them. Is that all right?
Yes, madam.
Or do you want to discuss these two slides also if you have time? I don't mind. Do the people want to go?
Grief,
No, madam, you can carry on.
grief is okay, madam. Please
You can
continue.
continue.
We continue. Okay, right. It's two slides. So grief, I just mentioned grief because it's usually been overlooked in the community. So elderly people present with grief because they face with lots of losses. They lose their children, friends, spouses. They lose their job. They might lose their limbs. So lots of grief issues are involved in old age. So grief is the physiological and psychological response to bereavement. Many people go through normal grief process and they recover, right? The problem is a minority of patients can present with complicated grief. So in this group, need specialized care and support. So these patients will again come to you commonly. So I thought it's important for you to know something about grief because you can recognize grief. So complicated or abnormal grief is when the grief is abnormally severe. Sometimes the patients can't return to their norm. People can't return to their normal functioning. They don't eat. They don't do anything. They might have depression. They might have suicidal thoughts. So when the grief is abnormally severe. Sometimes it can be prolonged. After 4 or 5 years of the loss, the patient is still having significant grief. So in those instances, they need special support. Usually it's psychological. So the important thing is to identify, recognize, and refer for appropriate care. If they have comorbid depression, then it can be treated with antidepressant medication, but otherwise they need psychological therapy. Okay. Just a few words about psychosis. So psychosis is a huge topic. So psychosis, they can present with delusions, hallucinations, disorganized behavior, disorganized thoughts, and so on. When a patient is presenting to you with psychotic symptoms, we need to consider lots of differential diagnosis. So that is the important thing. So you can't just treat with antipsychotic medication. Whether this is delirium, whether this is dementia, depression, schizophrenia, other psychotic illness. They might have organic psychotic disorders like when they have Parkinson's or encephalitis or things like that. So it could be a result of psychoactive substances or medication. So we need to keep all these causes in our mind when we see a patient with psychosis. So the management is challenging. So the wise thing would be to refer these patients for secondary care when they present with psychotic symptoms. Right. So yes, so that's it. Do you have any more questions?
Excuse me, madam, when we are using the benzodiazepine for the elderly patient, what is
Yes.
the best drug we should use?
Yeah, if you really want to use the benzodiazepines, better to use short-acting ones. So alprazolam can be used for anxiety symptoms, but it's not a very good sedating medication. So if you want to treat sleep problems, lorazepam, or in the private sector, you have temazepam, oxazepam, and those kind of things. But don't use diazepam or clonazepam, which are very long-acting and can be troublesome.
Thank you, madam.
A few questions in the chat box.
Okay, let's quickly have a look. How to handle right. Augmentation of action with SSRI with antipsychotics. So it happens at the receptor level. So SSRIs can be combined with low-dose antipsychotics like risperidone 1 to 2 milligrams or olanzapine 5 milligrams or aripiprazole to give a combined effect, which is more effective than antipsychotics alone, antidepressants alone. Then how do we identify complicated grief? So yes, so it's complicated grief is when the grief is very severe. It's not normal. The patient is not functioning normally, or the patient is severely depressed. Patient could be suicidal, or it could be abnormally prolonged. Usually after 1 or 2 years, the grief is resolved. So sometimes it can be prolonged. Then you can refer. What antipsychotic drugs cause EPSC, whether combined with benzexol, justifiable. So first generation antipsychotics cause more EPSC. So because of that, they are not recommended to be used in elderly. So haloperidol, trifluoperacin, those things are not recommended usually. So risperidone, olanzapine, those medications can be used. Usually olanzapine is the least likely medication to cause EPSC. You can combine with benzexol, yes. But again, benzexol also has side effects like it can worsen cognitive impairment further. So always try to use lowest doses of antipsychotic medication. How to handle excessive masturbation in male elderly homes. So that is a different topic. So we need to analyze the patient's behavior well. Why this patient is behaving in this manner. So whether this is really excessive or not, or whether this patient is just expressing his normal sexual needs, because in an elderly home, he doesn't have any means to satisfy his needs. So, so if it is not clearly excessive or if it is not harmful to anybody else, the best thing would be to train him to do it in a safe manner, which does not disturb other people. So if you think that the patient is having excessive sexual desire, then you could try some SSRI medication to reduce his sexual desire. But it's not very ethical if the patient is having usual sexual desire. The sertraline cause yawning. Yes, some people, I have seen some people having that problem. Does clonazepam cause cognitive decline in chronic use? Yes. So benzodiazepines, any benzodiazepine, if used in long term, can cause cognitive impairment. Is that all? Yes. I think I have answered all the questions.
Doctor, I have one quick question.
Yes.
When we look at a patient currently having dementia, is there a way to detect or distinguish between any kind of a progression from dementia into Alzheimer's without going through actual like MRI or any clinical study, just by the behavior attitudes? Because even to, I'm speaking on a personal case with my mother, to get her to do a MRI at her state will be a very difficult task than to sedate her and try to get an additional reading or something like that. So
yes, looking at the progression of the illness and the clinical features, we can sometimes say whether this is Alzheimer's or whether this is vascular and so on. But what happens is usually when it comes to later stages, when it comes to the severe stage of dementia, it's quite difficult to differentiate. Yes, so that's the story. But at early stages, usually we can differentiate clinically, not all the time, but usually because the slow progression, initial involvement of memory, retained insight at the early stages, and so on. But these are not confirmatory.
So when it's Alzheimer's, is it more of a physical impairment and mobility, or is it also more on the cognitive side and mentals?
The Alzheimer's disease is the commonest cause for dementia. No? So Alzheimer's disease usually presents with slowly progressive cognitive impairment. Memory impairment is usually the earliest feature, and other cognitive domains are affected usually later in the course. Yes, so that's the only way to differentiate.
Excuse me, madam?
Yes.
As a general practitioner, to start the momentum or donation, do we have to always refer to the consultant or psychiatrist or geriatric consultant?
That is the recommendation. That's not a rule. That's a recommendation because so this could be something else also. That's why. So there could be a treatable one, or it could be a depression or something else. That's the recommendation. If it's very clear-cut dementia, then you might want to start.
Okay, thank you, madam.
Okay, are there any more questions? Hope I have answered all the questions well.
Yeah, it's a very nice session, ma'am. Thank you very much. I think it's time to wind up. And thank you very much for your valuable time. And there were more than 70 GPs in the audience, and some of our friends as well. I think that they all got their answers, but with this short time, you could enlighten us on various things. Madam, can you stop screen sharing, please?
Oh, okay. Sorry. Okay.
Yeah. We have this certificate for you, if you can see, ma'am. At the appreciating you for joining our session, signed by myself and our president, Dr. Matthew. Right.
Okay.
So
Thank you very
everyone,
much.
thank you very much for joining us today, and good night, and have a nice weekend.
Okay, thank you.
Thank you, madam. Thank you, Asita.
Thank you, madam. Thank you, madam.